disclosures. So this patient is a 53-year-old male. Pre-dialysis main comorbidities are smoking and hypertension. So just as a reminder, we have the superficial venous network, which is the basilic and the cephalic vein, and they're connected with the perforator in 85% of the cases, with the deep venous network that is accompanying the arterial network, namely the brachial artery, the ulnar artery, the interosseous artery, and the radial artery. So before we create the fistula, we will start with the screening. I think this is the most important part for creating an endo-AVF, so I will stick to this, and I will show you the way we think and concluding to what we want to do. So from the radial side, you can see the measurements that the non-arterial or the venous part have more than 2 millimeters. So this is the baseline for both accessing or creating a fistula. So the radial side is off. Going to the ulnar side, you can see that at the side of the anastomosis, we have sufficient vessel diameter, both for arteries and the veins, both the medial and the lateral ulnar vein. And the good thing is that we have an artery of 2.5 millimeters when we see the measurements at the wrist. However, we don't have any veins there, so it's not an option to get an access from the ulnar side of the wrist. Then we also need to check the cephalic vein, medial, proximal, and distal, and you can see here that the diameter is well above 2.5 millimeters, and also, another important thing, the depth is also sufficient for a patient to be cannulated. Going to the basilic vein, you can see that the diameter is a bit bigger, and the distance from the skin is deep, so we cannot use that vein apart from the distal part, where you can see that is borderline 5 millimeters distance from the skin. However, the diameter is quite good. Then another thing we need to check is the median cubital vein, also sufficient diameter and depth. So if this patient will actually have a fistula, he can be cannulated both at the cephalic and at the median cubital vein. So the perforator, also very important. You can see that the 3 different measurements are adequate to have a WavelinQ fistula. And the brachial vessels, here you can see that the diameter for both the medial and the lateral vein are of adequate size, so we can use those vessels to go down to the ulnar vein. So from our measurements, we can see that we can use both the brachial artery and the ulnar artery for arterial access, and we can use only the brachial veins for venous access, like you see here. So we actually have 2 plans. Is either we go wrist or brachial access for the artery, and we're definitely going to go brachial vein. We picked the ulnar artery, brachial vein, the antiparallel approach, because it's always easier. If you get wrist access, then you put the radiostop there and everything is done, and it's much easier than pressing the brachial artery. So always the puncture starts with the venous part, under ultrasound, of course. We insert the sheath, and we use the catheter, angle catheter, most of the cases, to cannulate. You can see in this image that we can see the basilic vein, we can see the median cubital vein, we can see the perforator, we can see the ulnar veins, but what we don't see is the cephalic vein. So someone might say, you know, this is not a candidate, but we know from the ultrasound that this patient did have a cephalic vein. We go wrist access, ulnar artery. We did this procedure under local anesthetic. We don't use it if we go wrist access for the vein, the local anesthetic. First we puncture and then we give it. We don't want to compromise the vessel. In this case, once we get access, we will also give 5,000 units of heparin. This is the arteriogram. You can see as a last check, not that we didn't know, that all of the arteries of the forearm are patent. You can see the radial artery, the ulnar, the interosseous, and of course the common ulnar. And now this is another angiogram where you can actually see that the cephalic vein is not missing. It was just a spasm, maybe because of manipulation, maybe for some reason the wire might got into the perforator and then to the cephalic. So that was only for a small period of time. We do have the cephalic vein there. And that's how the axis looks like. So you can see this is the brachial vein, this is the ulnar artery, this is the antiparallel approach. You can see that the indicators of the device in the venous part, they look down because the axis was high up. And in the case of the arterial axis, the catheter has the two indicators on top because the axis was gained from the ulnar artery. So activation takes place. That's what we get here. You can see that the contrast is going from the ulnar artery up. It's going through the anastomosis, and we can see both the cephalic and the basilic vein. Since we punctured the brachial vein for access, it sees that we do see contrast in the deep venous system. It was our decision to coil one of the two brachials, the one that we have our sheath in. So some people might say, you know, we're a bit reluctant about embolizing one of the veins. Ideally, we don't embolize the vein, we're just coiling the vein, and we just make it a bit more difficult for the blood to pick the deep venous system. So a bit more resistant, it will help the blood to go through the perforator. So this is the result. You can even see that we still have flow. It might obstruct, might not. And you can see the different components. So you can see down there the ulnar artery, the contrast is going retrograde. It goes through the anastomosis, lateral ulnar vein, perforator, basilic cephalic. Immediate volume flow at the brachial artery was 1,160 mils per minute. And this is what I like because generally I couldn't understand in the beginning. So this is overlapping the fluoroscopy over the hand to get a better idea of how this fistula is created and where it looks. Because people often wonder when they want to cannulate where exactly is the anastomosis. So this is where you should be expecting it. Thank you for your attention.